I'm going to speak exactly about the topic that is the osteoporosis, the osteopenia, and the premature ovarian failure. The first thing that I need to say that this is a beautiful topic because we have any idea of what to do in a lot of occasions. There aren't any protocol, there aren't any guidelines. In fact, there is a huge hole in this area. But at the same time, it's very, 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 very important. And maybe we can discuss. We are very few people here, and we can discuss this topic because we have here the President of the European Menopause Society and some other experts here, John Stevenson and my friends, that maybe this could be open, the possibility to do something in this point. I am going to speak briefly about all of these points. This is my agenda for today, for the next half an hour, or maybe 25 minutes, because I know that the one speaker is not going to be here, and we have more time. The first thing is that the confusion about early menopause, premature ovarian failure, or premature ovarian insufficiency. There are very, very big confusion about what is what. We can say two things. First, that maybe early menopause means that there are women with bilateral oophorectomy, that this is one kind of early menopause different than the premature ovarian failure or insufficiency. In fact, women with bilateral oophorectomy, they have a very acute hypohysteronism. That means several things. First, that probably this kind of women, they need more estrogens than women with premature ovarian failure or with insufficiency. That means that we need to differentiate clearly what is what. And in terms of bone mineral density and risks or fracture risks, is exactly the same. Probably the group that is in your left could be in a very high risk in comparison to the other group. Other beautiful point is to determine what exactly are the percentage of women that they are suffering of premature ovarian failure. We can say that probably we have in our Caucasian women 1%, but this is very nice to see that the differences between the American, African American, and Latin women, that they have more percentage with premature ovarian failure in comparison with Chinese or in comparison to Japanese people. But here there are two conclusions. First, how important are the genes? And this is exactly the topic for the future. What are the genes that they are involved in premature ovarian failure? And the second one is, for example, in my country, 1% of ladies mean that we have more than 70,000 women in Spain that they are suffering premature ovarian failure. This is something to take in account in our minds. As you know, the relation between estrogen and bone is clearly, this could be perhaps one of the major points. It's in Spanish, all of the words, but I'm going to explain. If you see the red line, that this is the women line, you can understand that it's completely different if a woman suffer the menopause before 30s, or in other words, before having the peak of bone mass, or after this. One thing is here, and another is maybe here when she lies to have the normal peak of bone mass. Here again, it is not equal to prescribe estrogen here, then maybe we need to prescribe more estrogen than here, if you like to maintain the bone mineral density. That we can say that this is different, the premature menopause failure in women before 30s than after 30s. This is another issue to take in consideration. You know how important are the estrogen for bone mineral density. It works in the osteoblast, but perhaps it works more as an antiresorptive drug through different mechanisms or different pathways, but perhaps the RAN ligand could be one of the most important ones. But the point is that they destroy number of osteoclasts, and they produce a clear inhibition about the osteoclasts. This is important to understand what's happened in the natural menopause with the bone mineral density and to understand what's happened in the premature menopause or in the premature menopause failure, if you prefer, or insufficiency. You see that when the menopause arrives or when the estradiol decrease dramatically during the next 5 years, or maybe before 2, in relation with the last menstruation, and during the next 4 or 5 years or around the menopause, there are around 10 to 15% of loss of bone mass. This is clear. And not only this is a very old but beautiful picture that they show clearly that independent of the bone mineral density, the number of fractures, they are in relation with the level of the estradiol or estradiol level. This put in consideration here that this is going to be very important to think about what is the ideal estradiol level in the women in terms to maintain the bone mineral density, or if you prefer, to prevent fracture risk or to prevent fractures. What we can say about the effect of early menopause on bone mineral density? Of course, if you stop estradiol or you decrease estradiol, you in this moment start decreasing bone density. But again, I can say here that it's absolutely different if you start here in this point, or if you start here. Again, here we can say that before 30s and after 30s is going to be very important, because before 30s we have an important mission, is to try that these women, they will reach to have the normal peak of bone mass, and after is only to maintain the bone mass. Let me to present this. This is the unique study in the world where analyze the differences in women with menopause, premature ovarian failure before or after 30 years old. And they say that they are completely different. When you analyze the telepeptides, for example, and the lumbar spine T-score, you need to understand exactly that there are differences between these two groups. This again is so important to understand the differences in terms of age. Let me now to discuss with all of you something about the diagnosis in relation with bone mineral density. You know that the WHO organization classification in relation with the osteoporosis is when there are minus 2.5 or more below the young adult mean. This is exactly the definition. But what's happened? What's happened when we are speaking about young women? Well, this is not very easy. We have no clear if the T-score is the real parameter for analyzing the osteoporosis, because T-score is something logical for postmenopausal ladies, but no for younger ladies. For younger ladies, we think that the SIT score is more important because compare the bone mass density with that of someone of similar age. If you see here, well, one thing is T-score that you need to analyze with this point, that will be okay, but with the SIT score you analyze with the same age group. Imagine that you are in the 30s or in the 20s. This is ridiculous to analyze with the T-score, and it will be much better to analyze and to make a diagnosis with the SIT score. In conclusion, there is no big discussion because never in any IOF meeting, International Osteoporosis Foundation meeting, this item was discussed. I remember in this place we had a meeting of the IOF 5 years ago, something like this, and never this point that the premature ovarian failure was discussed in terms of bone mineral density and in terms of fracture risk. But I think that probably the SIT score is much better than the T-score for making a diagnosis in younger premature menopause ladies. This is one important issue to discuss, and maybe we can discuss this thing in one of our societies, and to understand that this is probably one important issue. What about the relation that we have between early menopause and fractures? If you look at this slide, you can understand all it. All of the papers that they analyze the relation between early menopause and fractures, they say that they increase dramatically the fractures in all kinds of early menopause. 50%, 100% in the college fractures, 300% in relation with heat fractures, 300%, 40%, more or less the same. No doubt about that early menopause increase is a real predictor of osteoporosis fractures. Not only this is a beautiful summary of two papers that they say, well, in women younger than 45, if they have a oophorectomy, that means that acute hypoestrogenism, they have a risk that is around 39% more. If the women, they have an hysterectomy but no oophorectomy, as you know, they decrease the blood flow for the ovaries, and they have a little less estradiol, but not as the oophorectomy. They have more risk, but not at the same level. In natural menopause, in women that they have the menopause before 45, but natural, they have a little increase because they are younger, but not at the same level. And finally, if you remove ovaries in women after menopause, you are going to have the equal risk of fracture than natural menopause. This is something that they saw how important are the estrogens and how important estradiol is. This is so nice to clarify in terms of bone mineral density what's happened. Well, let me to discuss the question here about how we can prevent in these women the fracture risk, but in general, everything, as my colleague said before. Of course, the first line and the unique line that we can do is to prescribe hormone replacement therapy. Absolutely. For several reasons. If you have, imagine, primary amenorrhea, well, you need to induce development of secondary sexual characteristics. You need to prescribe a lot of estrogen. If the women is after 30s or around 30s, to relieve the immediate sequelae of menopause, symptoms and so on, to prevent the long-term, as my colleague said, sequelae of the menopause, osteoporosis and cardiovascular diseases, and to create an environment conducive to successful replacement of donated embryos. That means that mandatory to prescribe estrogen replacement in women with premature ovarian failure. Well, there are some consideration here that this is something important too, to clarify. Of course, the first conclusion when we are speaking about route and type of HRT is that, of course, we need to have in consideration the individual characteristics, the clinical history, and so on and so on. But the reality, I'm very sad, is this one. No control studies. There aren't control studies. I can say one thing, and my colleagues or you can say other. And I can say, so sorry, I don't know. We have no. Could you believe that we have no control studies in this area? But we have no. Well, in principle, for this reason, no oral estradiol progesterone preparation can be much better monitored by what is. And the second point is, well, the point for me is, and this is, for me, the major issue. What is the ideal estradiol level? 60 picograms per milliliter? Why? 70? 80 picograms per milliliter? What are the normal levels of estradiol in women before 50s? We can say around 80. That means that the idea but this is only theoretically speaking because we have no data, is to maintain levels around 60 picograms per milliliter. But well, this is because I say this, because there aren't any data to show that 60 could be the best one, or 70, or 65, or 75. We don't know. That means that this is another important point to put here and to say that we have no data in this concern. We have some other data more clear. For example, we need progestogens when they are uterus and premature menopause failure. That always if they have uterus, we need to prescribe progesterone or progestins. Even after radiotherapy, that this is an important issue, this is clear, even after radiotherapy. Aim for minimum effective oral doses, this is something that all of us we know. Aim for natural progesterone replacement, progesterone, micronized or dihydrogesterone. They are, in theory, the much better. Let me now to say something too important. The idea about timing. Of course, agree with my colleague that the timing could be immediately if curative procedures. That means if the women that she has the premature ovarian failure, we know what the reasons are, and we can start prescribing in this moment. But imagine that the women, they have a premature menopause due to an endometrial carcinoma, for example. In these cases, you need to wait 1 year free interval before starting HRT. You know, all of the estrogen-dependent cancer, you need to wait around 1 year before starting HRT. Treat and less anti-leverage, I agree with my colleague, and HRT holidays to test ovarian function. If you have some doubt about if these women is starting producing hormones, that this could be, maybe you need to stop and to see what's happened during 3 months and then to decide what to do. Well, what can say more? This sentence for me is fundamental. In younger women, in premature ovarian failure, in premature menopause, data from the WHI do not apply. This is not for us, the WHI, nothing to be in comparison. This is something mandatory, obligatory to prescribe HRT, and the WHI here is not relevant in our case. Another point, thus, when we prescribe HRT, does not prevent ovulation and pregnancy. Maybe you need to avoid surprise. Young women without ovarian function may require more estrogen than older women. This is not the same, a lady that she's in the 20s, that a lady that she's in the 40s, or in the 30s, near to the 40s. This is again that maybe we need to think about what is the doses depending on the age. And there are virtually no data regarding the safety and efficacy of estrogen plus progesterone in women with POF. Could you believe there are no data? But well, you have the idea that this is logical, that in women, normal women, that they have their own estradiol. Well, this is more or less the same risk, but we have no data. Let me now, it was a joke. I was here in an North American OG Congress in 2003, and was so funny, because the North American Society decided to do, during the Congress, a survey. It was so funny. Let me to show you the conclusion of the survey. They say, do you prescribe to all of the gynecologists that were there hormones to women that they are suffering POF, idiopathic POF? They say 94, they say yes. No, 6%. Well, in 2003, near to the WHI. What kind of hormone you are prescribing? And the North American, only was not for us, only for the North American doctors. This was not for Iranian people that we were there. Combination oral contraceptive, the majority of them, the gynecologists, they are prescribing for premature ovarian failure oral contraceptives. Continuous combined ST, 16, and sequential ST, 22. I mean that there are no roles, again. And in relation with the question about how long should a woman with POF be treated, the North American colleagues answer it. Until the expected age of menopause, 67%. For the remainder of her life, well, 11%. Well, for 1 to 5 years, 11%, and on 13, 11%. What I saw this because there are no roles here, and in fact there aren't any papers to compare oral contraceptive versus natural HRT or HRT. We have no data to say. But, say, well, POF and increased risk of side effects. Do you know if these women, they have more risks? Yes, 25, no, 38, and uncertain, 37. Again, we can say that there is a huge hole here that we need to study a little more in this concern. And what's happened? And when a North American doctor, they say something or they do something, immediately our colleagues from UK, they do something similar. And the British Menopause Society, 2 years ago, they say something similar. And the answer was 56.2% of the clinicians in UK could prescribe hormone replacement therapy in women with POF. The majority of them, they change a lot here. The majority of the UK doctors, our colleagues, they prescribe estrogen plus progesterone and no oral contraceptive as the North American one. And the majority of our colleagues in UK, they are prescribing transdermal estrogens more than oral estrogens. Well, you have now here one idea what's happened with our colleagues in UK. I don't know if they are going to change after Brexit. But if no, this is something that this is the reality. This is a beautiful paper because they say what's happened now, what we are doing now. Well, but this is something very, very sad, this paper from the Human Reproduction the last year or 2 years ago. They say in Swedish women between 40 to 45 that only 0.9% of these women, they are with HT. And a majority of these women use less than 1 year. Oh my God, this is a very sad history. Well, something very briefly because I know that I finish my time.
You are 5 times more.
Thank you. You are a good friend. I need these 5 minutes. Then, of course, I am speaking about bone mineral density, and I am speaking about fracture risks. Of course, you need to have in your mind that calcium is there, daily weight bearing exercise, and daily vitamin D, and as you know, the vitamin D is very important in this concern. And there is here in the atmosphere one idea about these people. Probably in women with no ovaries, maybe we need to take in consideration to prescribe androgens, maybe, why no? And in women with menopause ovarian failure, probably no. But in women with no ovaries, could be. This is something that is in discussion. We don't know what to do. In fact, we don't know what to do because there are no data. That means that, well. Finally, what's happened? I'm going to answer the question of my colleagues, the president of my European Society. HRT. HT is exactly the treatment, but I am going to analyze if there is a contraindication in the breast cancer women, for example, what we can do in this way. Well, fortunately, in this kind of women, there are more data. We can say, for example, there is the idea through the breast cancer patients that in women younger than 40, 45 years old, with a T-score of minus 1.5, we can treat with biphosphonates. That means that this is something from breast cancer patients. And not only this, if you have a patient with premature ovarian failure or menopause that she is taking aromatase inhibitors, you need to take in account that these women with ovaries suppression, and they are going to have around 7 to 8% bone loss per year. This kind of women, this is mandatory to treat or with bisphosphonate, and more or less now, the denosumab, there are some data in breast cancer women, but no in premature menopause women. That means that the denosumab is there, but bisphosphonate now is the gold standard in women that they cannot take HRT, because the gold standard for women that they can take hormones are absolutely estradiol. This is important. My conclusion is that, well, this is a beautiful topic, but we need all of us more data I put here 4 points, but maybe it could be more. For me, the most important is what form of HT is most appropriate. Probably here, I agree with my colleagues from UK that transdermal, estradiol plus dydrogesterone plus progesterone micronized could be the most logical situation. But well, I don't know. What estradiol level is the best? 60 picograms per milliliter? Could be the idea, but we don't know. For how long should HT be administered? I agree that we have the philosophy, and this is absolutely logical, that until menopause at least. But well, we have no data. And how safe is HT in women with premature versus natural menopause? A lot of questions, but until having conclusion, we need to be logical and to do exactly as our colleagues in UK they are doing, because this is absolutely logical. Thank you so much.